I'm going to ask you a couple poll questions. This way we get to know about you and the audience here. So this first one is, what is your current professional role? I hope you can see that. Yes. What's your current professional role? Are you a counselor, therapist, social worker? Are you a nurse or nurse practitioner, physician or physician assistant? Are you a program or unit manager, university student or faculty, or other? And if you are in the other column, please, you can put your occupation in the chat or the questions box so we have that for our records. We're limited to 5 options here in this webinar program, so we can't put in as many fields as we would like. Okay, thank you. I will close it at this time and share the results. Okay, for the speakers listening here, we have 25% of the audience today are counselors or therapists, social workers, 33% nursing, 13% program or unit managers, and 4% university student or faculty, and 25 other. So I'm hoping that we will see that in the other text box to those. Thank you for that. Here's one other one. And this is, what field do you represent? Are you mental health, addictions, physical health, education, or EAP? Okay, thank you. I will close this now and share the results. Okay, our audience today is made up of 29% in the mental health field, 25% in addictions, 33% physical health, 8% education, and 4% EAP. And now these next two are really quick yes and no. So let's do that. Do you currently conduct SBIRT interventions, yes or no? Okay, thank you. I will share those now. Of our audience today, we have 29% do conduct SBIRT and 71% no. And this is the last one now. Thank you all for participating in these. Okay. Do you see your agency using SBIRT? So do they now use SBIRT, or do you see them going to SBIRT in the future? Okay, thank you. I will share these results now. Now for the speakers, 91% of the audience today, their agencies either use SBIRT now or will be in the future, and 9% no. So thank you so much for participating in that. We will now turn the screen over to our presenters.
Hi, Chris. So thank you. This is Holly Hagel. I am speaking, and I'm also the one on the camera. Chris, if you could make us an organizer, then we could help with the audio, too. Right now, we're just a panelist.
Oh, certainly.
Thanks. So I have in here with me today in the office, actually literally across the table from me, Dr. Ann Mitchell, who's the project PI for most of our projects that we are talking about, and Dr. Dawn Lindsay, who is our evaluator. Unfortunately, they are not on the webcam. And then also via the internet, and thanks Al Gore for the internet, I like to make that joke, but we have our project manager who is in Nebraska, right, Kimberly?
South Dakota.
South Dakota, I'm sorry. I'm sorry. I know you're from Nebraska, right?
That's true. That's true.
But she's literally in South Dakota, and she is on web camera. So right now, today, we are interprofessional in the presentation, and we see now that you've answered all those poll questions, we're interprofessional as an audience. We really take pride in the fact that we're an interprofessional team, and you'll learn more about that in the next couple of slides. I also want to say thank you to all of you for taking time out of your day and participating, and just explain that we're doing this webinar as part of our webinar series, SBRIT the Nitty Gritty, as you see on the slide, and that's part of the National SBIRT Addiction Technology Transfer Center. But most of the projects we're actually talking about really come from our parent organization, the Institute for Research, Education, and Training in Addictions, and our collaboration with the University of Pittsburgh School of Nursing. We've been working together over 8 years on various projects, and these are 4 of them. And so we're kind of wearing 2 hats, so to speak. The National SBIRT is presenting this, but this work is done on different subcontracts that we have with the University of Pittsburgh School of Nursing. So I wanted just to clear that up. But we are doing this as part of our Nitty Gritty webinar series because we we just started our 3rd year of our grant, and we really wanted to get into talking about how things are implemented on the ground as much as possible. And please, if anybody in the office do want to chime in, that never bothers me to people to speak. Okay, so here's the team I was talking about being interprofessional. There's Dr. Ann Mitchell that you can't see her on the webcam, but you can see her on the screen. And Chris, you'll let me know everybody's viewing and hearing me okay. And if not, you'll tell me. Thank you. And then we have Dr. Kathy Pushkar, who's one of our another project principal investigator for these projects that we've all collaborated with over the last 8 years. You have Dr. Irene Kane, who is, again, another faculty collaborator all these years. We're all like sisters now, really, to be honest. And our team continues. This is not even the whole team, really. It's the core team. We have another faculty, Dr. Marie Ferivanti. And then there's the IRETA staff, myself and Dr. Don Lindsay. So I hope you're seeing on the slides the different expertise we bring. We have nursing faculty, but I'm an educator in behavioral health sciences. Don is a psychologist and a evaluator and researcher, so we are very interprofessional in our interactions. Oh, Kimberly, I'm sorry. We don't have a picture of you, but at least you're on web camera. Can you tell us about your background?
Yeah, I came to the University of Pittsburgh as a project manager, and I came from kind of the nonprofit world, working with grants implementation, so this was a wonderful opportunity for me to be part of health implementation, and I enjoyed, working with my colleagues at the University of Pittsburgh and IRETA.
Well, thank you, Kimberly. I'm sorry we didn't have you on the slide. And I can't understate that we really appreciated, we've worked with Kimberly over the last 5 years, and she just left our project team as a full-time staff member, but we've kept her on as a consultant because that team really valued her input, coming from, again, another profession, because this interprofessional collaboration really does strengthen us. Okay, so I'm just going to briefly go over the goals of the presentation. And that is to review these 4 screening, brief intervention, and referral to treatment. And we do know that we need to say that. We were trying to do the whole SBIRT model and implement that into projects for nursing students and nursing professionals. Okay, so I'm going to ask Ann to go ahead and talk about our projects a little more.
We really thought that this was an ideal time to present some of the overview and lessons learned from the 4 projects that we have done with nurses. First of all, because nurses are in a unique position in which to intervene with their patients about substance use and misuse, and also because nurses are the most trusted health professional, and that patients will often say that they think that it's okay for nurses to ask them about personal questions related to their substance use. And then also, and lastly, nurses tend to be key players in really coordinating and ensuring smooth communication through interprofessional collaboratives. So we have a few broad objectives for the webinar today, and the first is we want to be able to describe the implementation process across our 4 HRSA-funded projects, and then we'll review the results of the implementation, including both quantitative and qualitative data. And then we really want to spend a little bit of time talking about the successes around implementation, as well as some of the barriers that we have learned to overcome. And now I'll pass it back to Holly.
Okay, thank you. Well, as the educator on the team, I get to go over the educational methods. And I just want to say that we can take questions at any time. Chris mentioned you can raise the hand panel. And Chris, I do see somebody's raised their hand, so if you could address that. You can also put them in the question or chat panel. We'll check them throughout. And then we'll stop and pause and see if there's any audience questions. If you don't have questions, you might have a reflection or your own idea that you want to expand on. Again, you can type that in the questions or chat panel, or you can raise your hand and we'll try to unmute you. We won't promise there won't be echo or background noise, but we'll do our best to make it an dialogue. So you can see on the slide that we used a variety of methods across different projects, and we can, when we review the project, we can highlight different methods that we use. But we did use face-to-face didactic instruction within many of the traditional school settings or face-to-face training settings. Chris, I see a panel, a little pop-up that says there's difficulties with the audio conference. Are you hearing us okay?
Yes, I'm hearing you. So I haven't gotten any. If anybody else is having problems, please send me a chat or a question, because I haven't gotten anybody who's responded.
Yeah, let me check our web connection, Chris, because it says we're pretty low. Our internet connection has to be reestablished. So I'm going to advance the slide. Are you seeing a move?
I am, yes.
Right now it's on educational methods.
Yeah. Okay. Are you seeing Project 1?
No, I'm seeing half of my slide now.
Yeah, I think our laptop has a bad connection.
You want me to pull up the slides and work them from here?
Yeah, go ahead, and then I'll talk and simultaneously reboot.
Okay. Okay. Yeah, do that.
Tell me when you're ready, Chris. We apologize for this delay, but go ahead and take the function back and pull up the slide.
Pulling them up.
Chris, I made you the presenter. Chris, can you give us an update verbally?
Yes, I'm just pulling them up right now. Let me.
Okay, I might have fixed it. Let me see if it works. I'm going to take back the presenter.
Okay.
And show my screen and connect from current slide. Okay, just let me know, Chris, if you're seeing, or Kimberly, it moved to Project 1?
Yep, Project 1.
Now barriers?
Yep.
I think I fixed it. It was a slow internet connection. Okay, so I see some chats. We'll circle back to them later. Chris, I think we're good to go, so I'm going to continue on. Are you okay?
Yes, thanks. I'm going to address the chat.
Yeah, can you mute yourself, though? I think I hear some background.
Yes.
Okay, so again, now we're back. So the educational components were the traditional didactic. So we had students in class. We also did traditional training face-to-face with nursing professionals. We had an online booster that's probably about 30 minutes long. We did many different types of simulation activities with standardized patient actors, and we really broadened the interprofessional component by adding an interprofessional case conference. So it's more of an application learning after they do the in-class or the booster. They're able to apply it across professions. And then we, in addition to the simulation with standardized patients, we changed the types of simulation. So it wasn't just patient-focused. We did focus on the impaired professional component. Because again, we taught both nurses that are pre-service, and we taught professional nurses. And these are issues that they're going to be and are currently possibly dealing with. And then, the second under simulation, number B, or letter B, the pre-op college student. That's a good thing because these are also live college students that see heavy drinking patterns. So they're not only nursing students, but they're college students that see high-risk drinking behavior. So that often came up in our pre-service education component. That's just a broad brush of the educational methods. I don't know if anybody on the team wants to add. Ann, do you have something to add?
I just wanted to comment that the simulation exercises really became a very strong component of the program.
Yeah, I think that's a good segue to the next slide. I think we're actually expanding that component currently in many of these projects because of the things that you're seeing on the slide. The students feel more confident, and I even think the professionals, if we add a simulation component, we have a role play component for our professionals that are doing training, but the simulation with standardized patient really improves their proficiency, their confidence in doing it, their feeling of teamwork. We recently had a simulation at the dental clinic that involved a nursing student having a primary care interaction with alongside the dental hygienist student. So it promotes this idea of teamwork, and they could really apply it. Anybody else want to add anything? Kimberly, I don't know if you want to add anything.
I think that it's a very good overview, and now I think we can really get into the nitty-gritty, as you said, Holly, of how did we exactly do this, and how did we implement these projects?
Good. Well, that's a good segue into each of the projects. Overview. Am I missing a slide? Yeah, I don't see that. Okay.
Maybe I can just
highlight
some of the numbers that we're talking about from these 4 projects. To date, we are very proud to say that we have trained probably over 600 undergraduate nursing students now in the use of SBIRT. And in terms of the emergency department registered nurses and other personnel, we have trained close to 175 individuals. With the interprofessional anesthesia group and dental group, we're pushing 300 students and residents. And with the interprofessional collaborative practice model specifically located in the rural areas, we're reaching close to 85 working professionals. Across all of these projects, of course, the majority of participants were females, and the mean ages ranged anywhere from 23 for the undergraduate students to about 42 for the emergency department personnel.
Thank you. Okay, we'll try to get that slide up that has an idea of each of the slides. So we're going to go through each project, and I'm going to turn this over to Kimberly, and she's going to talk about the first project.
Great, thank you, Holly. So the projects that Dr. Mitchell just gave a quick overview of, I'm going to just go through those one by one, and we'll share our successes, our barriers, some data. So hopefully all of you who said in the poll questions that you're interested in implementing SBIRT, hopefully you can learn from some of the things that we learned, our growing pains along the way, and have success in your implementation. So the first project, the Addiction Training for Nurses project, was where we started. And basically, The University of Pittsburgh School of Nursing provided the setting. They had a willingness to better prepare their nursing students for practice upon graduation. And the Institute for Research, Education, and Training in Addictions, which was also based out of Pittsburgh, had that expertise in addiction training, research, and evaluation. So it was a nice collaboration between those two groups. So to increase the number of nursing professionals in the workforce prepared to address the needs of at-risk users of alcohol and other drugs, we designed an addiction training curriculum that we wanted to infuse into the nursing curriculum. The partnership began in 2006. We had pilot implementation, and then we received a Health Resources and Services Administration grant, and we were able to then more fully implement the project with an 11-module, 13-hour curriculum design. So in order to do this, first, of course, we needed to get the nursing faculty on board. We had a couple of champions. Dr. Mitchell, of course, was one of them, who really championed this being implemented into the curriculum. But we needed the rest of the nursing faculty to be on board as well. So we offered CEUs and had a few training sessions for the faculty members. This also included the clinical instructors, clinical preceptors. They received the CEUs, as I said, and we found that new faculty were always coming into the School of Nursing. This was officially a 3-year project. It still continues to this day, and the curriculum is still being used at the School of Nursing. But with the new faculty coming on board, new preceptors being trained, we needed a way to consistently train the faculty and get them up to speed on SBIRT. So we worked with our continuing education department, and we built an online module that could be taken anytime, anywhere, and we also infused that into a standing preceptor module that incoming preceptors were required to take as well. After training the trainers, then we looked for the right spot to put SBIRT into the curriculum, and we found a natural placement for it within the framework of an already established 15-week psych mental health course. There were 8 hours of in-classroom didactic education. That included 6 hours in the junior nursing school year, and then another 2 hours in the senior year as a booster. And in between those 2 times of didactic in-classroom training, we also provided some clinical experience. So there were opportunities for the students to practice SBIRT at their clinical sites. A couple of ways that we helped encourage the students' abilities and their comfort in doing this was we had role play scenarios in class. We also had simulation lab opportunities where they were able to practice before going into their clinical experience. And we also provided a really cool tool that we're going to provide to all of you as well. It's called the ROC cards, which stands for Ring of Knowledge. And within this Ring of Knowledge, it was like a little thing that the students could hold, put in their pockets of their nursing uniform, and it had the validated screens for SBIRT listed right there. So they could, and also the scoring, so they could choose, which screen to do, what their follow-up was going to be. And we also included referral to treatment information in there, so local, guides for how to refer someone within our location. We also had continuous quality improvement. There was a learning community meeting at the end of each academic term with faculty members from the School of Nursing, staff from the Institute for Research, Education, and Training in Addictions, as well as the clinical instructors. So if we can go to the next slide, we'll talk about some of the barriers and successes with this project. So one of our biggest barriers, I think, was that the students, they practiced SBIRT during their in-class training. They practiced SBIRT during simulation and in their clinical rotations. But our focus group data revealed that the students wanted even more practice opportunities in order to feel comfortable both raising the subject of alcohol and other drug use and then following through with the intervention. We also thought that maybe their barrier in feeling comfortable and wanting more opportunities was because they were pre-professionals, so they didn't know necessarily where they would be working, what field of nursing, which specific part of nursing they'd be working in. So that uncertainty about employment may have impacted their ability to be comfortable in implementing SBIRT. But our success was really the number of students trained. As Dr. Mitchell said, we're reaching probably about 600 students now that we've exposed, trained, and skilled in SBIRT. So those are nurses that we're sending out into their communities who are knowledgeable of this evidence-based practice and ready to implement it into their hospitals and community settings where they're working. And Dawn is next going to talk about some of our data results from this project.
Great. Kimberly, this is Ann. I just wanted to say thank you for that great overview of the ATN SBIRT project. One of the things I did want to mention was as we were going through and implementing the program within the psych mental health nursing course, that one of the ways to kind of allow students to have an opportunity for a bit more practice was throughout the course of the training program, we also included clinical experiences in their medical surgical nursing rotations and their obstetric nursing rotations as well. So I think that ultimately that really helped to increase their confidence.
Good point, Ann. Thank you.
Yep.
Okay.
Thanks.
Okay, this is Dawn, and I'm going to talk about some of our data results from these projects. The two instruments I'll be talking about today is the AAPPQ and the DDPPQ, which are the Alcohol and Alcohol Problems Perception Questionnaire and the Drug and Drug Problems Perception Questionnaire. These are two well-validated instruments that are good measures of provider perceptions toward working with individuals with alcohol and or other drug issues. So in the ATN project, what you see here is the overall results for the AAPPQ. And as you can see here, all scales except with the one exception of the motivation subscale did increase significantly from the pre-training to post-training time points. And then the third time point was called the pre-booster session, and there were no changes from post-training to booster. However, you wouldn't necessarily expect a change. What I think is good to keep in mind is that there were no decreases from the post-training to the booster session, which in some studies using this instrument, and really in overall attitudes, what you see is a boost after the training, and then it kind of declines. Very often declines back afterward, and that really wasn't the case for the most part here. Another take-home from this particular instrument in this setting in the ATN project is that it seems like the role subscales we're really seeing the most movement. So, these are students and they're pre-professional, so I think one of the things that occurred with the training was really an increase in their sense of their role as nurses being really appropriate for asking patients about alcohol and drug issues and so forth. So that was the AAPPQ, and the next slide shows the DDPPQ results, which were very similar to the previous slide. So all the scales except motivation also increased significantly. So I mean the DDPPQ was created from the AAPPQ as a template. They're extremely parallel, very similar instruments. So, in some cases we do see some differences between the instruments. In this case, we did not. So, and I will now turn it back over to Kimberly to go on to.
Well, can I interrupt here and just say, Chris, are there any questions or things we should address since we went over quite a bit of information?
Yes, I do have a couple questions. One of them says, I work in a primary care setting at a very large FQHC. I will be helping to support the workflow of SBIRT in our medical teams, in which medical assistants will be on the front lines of pre-screening and screening questions. Will this webinar address key training protocols for these nurse support staff in implementing of SBIRT, particularly as it relates to the frontline nursing and the vitalizing and grooming of patients in primary care settings?
I'm not sure we're going to talk that specifically about a protocol, but after this webinar, we would love it if we could specifically talk to that FQHC as the National SBIRT ATTC and maybe give you some TA or answer any questions, give you some further specific resources. We were specifically going to be, I pulled the question up for the people in this room. Kimberly, you could read it in the questions panel too if you
okay.
Maximize that screen. And we'll try to get back with you specifically about more protocols.
One of the things that I would say would probably be an important component would be the practice opportunities for the support staff to be able to really become comfortable with the screening process.
Yeah, and thank you for the question, though. This helps us understand and pace things and also maybe give you further resources we didn't think about offering when we put this together. Chris, any other questions? I do see a hand raised. Does this person want to be unmuted?
I can't see the list of participants for some reason. It's blank on my screen. So
well, I'll see. It's Michelle Agnoli. Would you? I'm going to go ahead and unmute you. Did you want to verbally ask a question?
Yeah, and she also has one in writing. She was wondering if you offer nursing CE credits when you train, like the emergency room nurses, and when you train professionals.
Yes, we did offer CEUs for all professionals. We always do that as an incentive for them to, and make it meaningful for them as adult learners. But you are unmuted, Michelle, if you wanted to ask anything further or get other clarification. Okay. Chris, anything else?
That's it, thanks.
Okay, we'll keep going. Kimberly, we'll turn it over to you again.
Okay. So as I mentioned before, we want to provide you with materials, and I saw there was a question about that, accessing educational materials. So here is our screening manual for nurses. This is what we used in the Addiction Training for Nurses student project, and we adapted this for the other projects we're going to talk about as well. So this includes a trainer's manual, those rock cards that I mentioned with the validated screens, handouts, PowerPoints. So we hope that you'll follow this web link and check it out. They're all free to download for educational use. We can go to the next slide. So for the practitioners and then those, the questions that we just answered about those who are in the field now working and how do we implement this at a place that's providing health care on a daily basis, we asked ourselves that same question. And so we wanted to get into working with emergency department registered nurses. So we extended our curriculum into 5 hospital emergency departments. We wanted to see how practicing nurses would react to it. So we worked our connection through the University of Pittsburgh Medical Center, and we identified these 5 hospitals. We initially expected to just train nurses, but as soon as the administrators heard about our goal for this project, they almost would always ask, if other people in their team could be involved. Their nursing assistants, their technicians, mental health professionals. And our perspective on this, and I credit, Holly and Dr. Mitchell, was that we didn't want to turn anyone away. We wanted to, work with the team that was in place that was going to be implementing SBIRT. So we opened the training to all the emergency department personnel who wanted to attend, and we added extra training sessions where needed. We started the project by meeting with the ED leadership. We asked them, how do they envision SBIRT working at their site? We would use a flow chart, helping them to envision, if someone walks in to the emergency department, what does that flow look like, from triage? How does that person, how does that patient get the assistance that they need using SBIRT? Once we had that buy-in from the administration, we would move forward with the training. We wanted to understand the specific needs of the emergency department, so we worked one-on-one with a nurse manager. We used a champion model, so that nurse manager became our champion. They were the person that we directly communicated with. The nurse champion then was the person who set things up with their staff, answered questions, made sure that we were available when needed to answer those questions, discussed any barriers with us. They were kind of, our inside view to what was going on at the hospital and how we could help meet the needs of that specific site. We realized right away when we'd plan a training session, though, that several people didn't show up. These were nurses. They were working nurses who were going to be pulled out of training for emergencies at all hours of the day and night. So we decided we needed to hold training sessions at all hours of the day and night, and that was very successful for us. This training involved a 1-hour in-person training, and then for the nurses we had a 1.5-hour follow-up that was online that they could complete when they had time, and we gave CEUs for both that in-person and that online training. Then we also implemented a one-on-one with a trainer. So we called this you know, an opportunity for these nurses to try out SBIRT and then receive some feedback in real time from our trainer on the floor of the emergency department. To be honest with you, though, that happened maybe 25% of the time, where there was a patient and the nurse and the person giving feedback, the trainer. The reasons for that were, you know, maybe nurse comfort, if there was a patient available or not, a patient that was, you know, coherent and not, you know, this is an emergency department, so they were sometimes in an emergency situation, and that's probably not the best time to be, you know, launching into an SBIRT discussion. But the way that we turned that into more of a success was that we said, okay, when we did have an opportunity to discuss with the nurses, we said, you know, what are the barriers that you're having to implementing SBIRT and asking these questions? When you find a patient, you know, who responds yes to alcohol and drug screening questions, how, you know, what are your next steps and what are your barriers to doing an intervention with them? We worked closely with each hospital on their documentation as well, but this was another barrier. The validated SBIRT screens were not always included in the electronic health record. So we talked with, you know, the higher levels about how we could get that implemented. We also, you know, had to think outside the box. So we were doing some ad hoc forms, PDFs, whatever we could do to help the hospitals get this implemented. So as I was saying, you know, our biggest barrier was probably the amount of training time that we hoped for and planned for was not always feasible in the emergency care setting. So the way we turned this into a success was that the trainers met the diverse needs of the different sites in both rural and urban hospital settings. We really had to take into consideration the specific needs of each site and make sure that we were holding on to the outcomes of training of what we wanted to accomplish, but also just being flexible enough to provide training in a way that met their needs.
Well,
Dawn, I'll pass it to you for data.
Oh, yeah.
Yeah.
That's a good segue into being flexible about training needs, is because we had a little technical difficulty, we lost a little time, so we do have to speed up to cover all the projects.
Okay.
So maybe what all the presenters will agree to do is just talk about 3 points so we can get to the end. So there you go. There's one team. We have, but, so Dawn's going to talk about some of the results.
Right. Thanks, Holly. And I will make 1 point per each of these slides, actually. So for the EDRN project on the AAPPQ, we did see all of the scales except the task-specific self-esteem scale increased significantly from pre to post. The thing that happened that I alluded to earlier here was that we did see some decreases at the follow-up time point. And I will say that the range of time between the training and the follow-up did vary a lot between sites and between the participants, so that, you know, that could partially explain that decline. And we did see some very similar results in the DDPPQ. On the DDPPQ, all the scales did significantly increase from pre to post. And again, you know, we did see a few declines, but a few of the scales did stay the same. So I will pass it back to Kimberly.
Okay, 3 points.
You didn't get much of a break there, Kimberly.
So our next project.
No. I did see, let me just interject. So I did see the message about the arrow, so I'll try to minimize opening up the screen and moving the arrow too much. Okay, Kimberly.
So our next project, we returned back to working with students. We know that nurses are a leader, and especially advanced practice nurses are a leader in the field. So we wanted to work with advanced practice nurses, and we know the issues of substance use within the anesthesia field. So we worked with student nurse anesthetists, and then we also connected with the dental students at the University of Pittsburgh because they shared a clinical opportunity. So we followed a similar trajectory in our training. There was an on-site training, a follow-up that was online for them to review, and then we had a simulation session. And a unique thing we added on for this project was a clinical case kind of review. So when they were in clinical together, these interprofessional anesthesia students, we had them talk about some of their cases and how they would approach using SBIRT in those cases. And we can go to the next slide. So our barrier here was just finding the time again to train student nurse anesthetists and dental students together and in classroom. We wanted to do that together straight from the beginning, but we know that these curriculums were very busy. So we approached the in-class trainings separately for the nurse anesthesia and the dental students, and then we brought them together for practice and simulation and those case conferences. Dawn, you ready for data?
I'm ready. Okay, so we're back to the AAPPQ here for this particular study. One thing we didn't have really a lot of time to go into was there were some baseline differences between the student groups in this study, but this slide you see does pool all the different types of students together. And what we see here is that we do have increases in the role adequacy, role legitimacy, and role support. So all these scales that are about the student's role or future role increase significantly across all 3 time points. And what's really exciting here, I was excited by these results anyway, was that the simulation experience really seemed to add value to to their sense of their role in doing SBIRT. And I think that's a really nice story, and it really speaks to the power of that simulation experience as something that's really important in learning this new behavior and applying it to the patients or simulated patients. You want to say anything else about that? And then on the next slide, for the DDPPQ results, we have very similar results here. The simulation experience, again, added value to and added to the role adequacy, role legitimacy, and role support, the student's sense of their role on that measure as well.
Great, and I'll pause here and ask Chris were there questions. I see some flashing hands and the comment panel, so. Nothing?
No, that was, there's just a comment here about a technical question, so
Okay.
I don't have any other questions.
We'll keep going. So then this is the 4th project that we're going to review, Kimberly.
All right, and with this next project, we wanted to reach rural professionals specifically. We decided the best way to do this would be through a 100% online program where we could meet lots of different professionals from lots of different agencies and expose them to SBIRT and see how they were able to use it within their specific organizations. Our initial goal was to recruit healthcare teams from the same rural county. We wanted to, again, offer them free online education with CEUs and then have them come together online over a webinar like we are on today to discuss cases and hopefully to improve their capacity and their ability to provide the best possible substance use care. We included modules on SBIRT. We also had interprofessional collaborative practice modules, case studies, and that interactive dialogue session where they could talk about cases in a live format and get that technical assistance feedback from the experts. And for barriers and successes, after we released this program and recruited participants, we found that the participants were having a difficult time completing the project. They might log in once and then we'd never hear from them again. So here's some examples of ways that we found successful to encourage completion. We offered small gift cards incentives at key points throughout the program. We created a standard of simple, straightforward reminder emails. Our team members visited the sites in person to answer questions, discuss barriers, encourage completion. We also gave the site leaders leadership certificates. So this was, a nice reminder of the project that they could hang there right on their walls. We often had just one or two individuals from one healthcare team as a part of this project. So we really encouraged those members to be advocates and champions for SBIRT, and we supported them in that role.
Okay, great.
On to data.
Okay, wonderful. So we see here that on this project, again, the scales having to do with role really were important for us to look at. So role adequacy and role legitimacy both increased significantly from pre to post training, and the story here is that interprofessional dialogue really seemed to boost the effect, especially for these role-related skills, so that interacting with other professions really kind of gave the participants a sense of their role, as well as the support of other professionals in conducting SBIRT and in putting these practices into play. So for the next slide, we have the DDPPQ. In this case, this is one case where we do see a discrimination between the alcohol and the drug-related items. So the drug-related, the DDPPQ really didn't have much movement here. Only role adequacy significantly increased from pre to post. On the other hand, role adequacy, role support, and work satisfaction all increased significantly after the interprofessional dialogue. So apparently the dialogue was really an important component of this overall intervention.
This is Holly. As an educator, I'm happy to hear. So, okay, Anne, would you like to talk about SBIRT?
Yes, I just want to mention a few things in terms of training students versus professionals. And I want to just say that in general, both the undergraduate and graduate students really appreciated the importance of being taught SBIRT, and they could see the importance of taking this work with them into their future job positions. The undergraduate nursing students in particular came back and said to us that many times they were offered a position because the person interviewing them was so impressed with seeing that they had been trained in SBIRT. And in terms of professionals, I think the lessons learned here was the importance of really finding time within busy emergency room or clinic settings for professionals to actually get embedded in the SBIRT content. And in terms of implementation, really identifying the correct person to do the screens in, say, an emergency setting would either propel the movement forward or could become a barrier if that was not clearly spelled out. And so just in terms of the data, the undergraduate students did have improvements with training, and the graduate students, not only was there improvement in training, but it had even additional impact after simulation. And one of the things that I was thinking about here is that with the dental students, we moved into using standardized patients with the simulation. With the undergraduate students, we were using high-fidelity patient simulators or mannequins. And I think having that real live person standardized patient had a huge impact on the students. In terms of some of our qualitative data and interviews, students really wanted us to give them many examples of ways to say things and ways to ask questions. They really enjoyed the role plays, and really having the opportunity to see how these options might play out in future settings was a help for them. And in terms of the professionals, okay, while the IPCP scores increased at follow-up for the emergency department registered nurses, the IPCP really, that follow-up increase could be attributed to the IP dialogues that Dawn had mentioned earlier. In terms of professional qualitative data, they often said that they wish they would have had this training much earlier. They really like the examples of how to incorporate this during into regular nursing assessments and nursing duties, and then watching the nurse interact and seeing that role model really gave them a way to communicate with patients in a non-judgmental way.
Well, speaking of communications, this is a good segue. We're going to end the webinar. I just want to let everybody know we have 5 minutes to the top of the hour. So if you have questions, please put them in the question or chat panel, and we will get back to you. I want to highlight that we will send you a link to the curriculum and the rock card and handouts that Kimberly mentioned, and then a conference that we're having this June. But I just want to highlight that I think you all know this as leaders, that communication is first and foremost. So I'm not going to belabor that, especially because the last point, we have to be clear, concise, and it should fit the setting. Our setting is we have 5 minutes. Administrative barriers, staff turnover, retraining, fitting in with those champions, that stability is very important. We can have a whole webinar on the electronic health record. We do on our webinar library, but we can have an updated one because that is an evolving field. It is very critical to address this for implementation. And billing, it is state by state. So hopefully you'll visit our website and see what resources we have about billing.
Okay, and in terms of what we learned, I think key is being flexible. You also want to be creative in your implementation strategies. And what we did was always use continuous quality improvement so that we would look at what we had done to inform what we were going to do next. In our next proposals, we need to begin to think about looking at patient-level data in terms of patient outcomes and satisfaction. And this is extremely important because of the importance of co-occurring disorders, with now over 200 physical health problems being in some way or another attributed to the misuse of alcohol. We just want to highlight that we do have a number of publications that we can send links to. And
then we'll just end on this slide. And Chris, if there is like 4 minutes left, if there are any questions, we can go ahead and address them. So we are having a national conference June 9th and 10th here in lovely Pittsburgh, Pennsylvania. We hope that you join us. The conference website is live, and we'll send you a link. We'll send you a link to it at the end of, with this PowerPoint, and also all of the end of webinar information that we send out to you. And we just hope that you come and share your expertise. If you are expert in implementation, you could do a poster session. And you'll get to be experienced with some of our simulations that we talked greatly about. And also, I know that more than half of you were novices to SBIRT. We have a specific track for you. So if you everything you wanted to learn about SBIRT and never had the courage to ask, you will learn at this conference. So we hope that you will join us this summer. It is very lovely in the summer in Pittsburgh. And come on out and either learn about SBIRT if you're new, or if you're experienced, let us know what you've been learning about SBIRT in your setting. Chris, anything, closing things?
I think that's it. We don't have any more questions. I will be sending out an email to all attendees later this afternoon that will have a link to the evaluation. It will have their NADAC and Pennsylvania counselor certification CEU unit for this event, and also a link to the recorded webinar and a link to the slides that are here and any resources that we might have used during this session.
Chris, this is Holly. I did see we got a question about are there SBIRT recordings, and I have to tell you, if you go to YouTube and you put SBIRT in it, you will see probably 100 SBIRT videos from all of the SBIRT funded projects. But we can send you guys a link to a lot of multimedia online sources for SBIRT. So if that's it, then I will thank you all for your attention. I thank you, Kimberly, in South Dakota. Sorry about my geographical lapse. And, well, I wish you all a happy holiday season, however you celebrate. That's it.
Thanks, Holly.
Thanks.
Bye-bye.
thank you. Happy holidays.
Thanks. I'll close it now.